good mix. You got scrubs, I got the.
That's right. Scrub a dub dub. Yeah, but we both live in scrubs. That's the thing.
Whenever you're ready.
Okay. Alright.
No, I think it's a good mix. You got scrubs, I got the.
That's right. Scrub a dub dub. Yeah, but we both live in scrubs. That's the thing.
Whenever you're ready.
Okay. Alright. Just roll with this because I'm going to have a little fun.
Go ahead.
Hey Facebook, how is everybody doing? You will notice that for the first time I have a man sitting next to me. He's better looking than me and I'm okay with that. I'm very comfortable with this. It's an ego thing. Philly told me I had to shut up and do it because I was getting boring and I needed somebody to spice this up. So, Alex Perez is a very good friend of mine. We're colleagues. How long have we been working together?
Probably 5 years.
5 years. 5 years. Yeah, it feels like 5 years.
Yeah.
Feels like 5 years. He is the chief of gastroenterology, and I am just a lowly surgeon. So, I was going to get out of the boring realm and bring in a guy who actually can answer a lot of your questions, because you guys have been throwing tons of questions at me about GI stuff, and I thought I'd bring on the man. But let me do a couple things. One, thank you everybody who follows this. This has been absolutely fun from the beginning. We said it was going to be about education, and that is one of the reasons why Alex is here to help us out. Two, please, please, please share this and link it. And also, we're going to send some stuff over to link to your crap too, so we can all be together. Just a bunch of educated crap. This is going to be awesome. The questions that you guys send in are wonderful, but please slide in some stuff to my DMs so I can get your questions answered. If you don't do it beforehand, then it's hard, live to do this on the fly. So please get them in there early and we get your questions answered. All right, so Alex Perez, oh God. Hi, Mom. If I don't do that, I get in trouble. You want to say hi to your mom? You can say hi to your mom.
My mom does not do Facebook, but hi, Mom.
That's it. Say hi to everybody else's mom.
Right.
Hi, everybody else's mom.
That's good.
Okay, so Dr. Perez, you might find him as Alejandro Perez because he's Cuban, but he goes by Alex for years and years and years and years. So, real quick, just so they know who they're talking to, where did you do your education?
So most of my training was down in South Florida. I did my internal medicine at the Cleveland Clinic down in Weston. Then I went up to New Jersey for 4 years to do my GI fellowship, and then just came back down home.
All right.
Found Vero Beach.
I like it. So let's do some rapid fire questions because that was important.
Sure.
But what's really important is
yeah, no one cares where I train.
nobody cares about it. Yeah, crap. No, trust me. They want to know. Well, what's your favorite workout?
Oh, well, that's a good question.
You got a new thing going, I know.
I'm pretty deep in CrossFit right now. I don't know that I can answer that with just one question, but some workouts that we do, they're called Metcons, which are really intense, kind of short interval stuff. Those kind of workouts where you kind of pass out on the ground when you're done.
Oh, that's it.
And you hate it while you're doing it, but you love it when you're going home. So that's probably my.
Don't let him lie to you. He was a wrestler.
Yeah.
Do you do clings or snatches?
We do both. Snatches and cleans and all that. Yeah.
All right, CrossFit junkies.
Yeah.
There's your boy right there.
That's
The face of CrossFit.
Yeah.
All right. Okay, number two. If you had to be locked in a room for 24 hours with Nancy Pelosi or Dr. Fauci, who would you pick?
Oof, that's a tough one. I'm going to go with Fauci. I think he's done a decent job. I'd like to pick his brain. He also just turned 80, which I think is impressive.
Just
he
turned
looks
80.
like he's 60.
Well, that's funny because you just had a birthday.
Yeah.
So if you could pick an age that you had to stay for the rest of your life, what age would it be?
That's a good one. I'm going to go with probably 35.
35.
That was kind of my...
Was that the last time your patient said, you're just a baby.
Are you old enough to do this? Yeah.
All right. How long does it take you to do a colonoscopy?
It depends. Some colonoscopies are more difficult depending on the patient's surgical history, their anatomy, things like that. I would say it ranges between very simple ones, sometimes 10 minutes, other times 30 minutes, but that's kind of an average. I'd say 20, 25 is the typical.
Okay, great. All right, so I think you kind of have an idea who you're talking to now.
Yeah.
So we'll get started. He's got some Cuban flavor too, Cuban background. Is that right?
Yeah.
That's it. And the food is good, and this man's wife can cook.
In the background.
You gotta be careful. Oh, by the way, we're remote at his house. He's been nice enough to let us come to his house with his big fireplace and beautiful chairs and get comfortable. So thank you for that, and thank you to your family. I think amongst he's got 3 kids, and I got 3 kids, so the 6 of them are strangely being quiet right now. I don't know how that's happening, but
they're in a food coma.
They're in a food coma. That's how we do it. All right, so let's go to a couple questions. I'm going to start with one of my questions because I think they're good. But they just changed the recommendation for colonoscopy. It used to be 50 years old, and now it's 45. But I know there's some caveats that, like if you've had family history and stuff like that. Tell us when people should get their colonoscopy.
So, first thing, the recent change to 45 was made from the American Cancer Society recommendations. They found that the highest group of cancers, or growing colon cancers, are being found in patients under the age of 50. And they, of course, did cost analysis and research behind this and came up with the new recommendation as a general screening for at-risk patients to start colonoscopies at 45.
Cool.
That being said,
so you're almost ready for your colonoscopy.
I'm pretty close. Yeah,
I think I'm even ahead of you. Like, you'll be doing mine very soon. Okay, but what if they had a family history?
Sure. So, big question we get in the office sometimes is, I have X family member that had colon cancer. What's my risk? When should I start screening? I think the first question is, which family member? We get most worried about first degree relatives,
right?
Mom, dad, brother, sister. We get very worried about early age of diagnosis. Anybody under the age of 50, definitely under the age of 40. We think those patients,
because they might have a genetic
they have a
predisposition.
stronger genetic, absolutely. So the general rule is, if it's a first degree family member, 10 years before their age of diagnosis. So for example, if your dad was diagnosed at 55, you should start colonoscopy at 45, right?
Right.
And on top of that, if it's a first degree relative, the guidelines haven't changed for a long time on this, but it's 10 years younger or the age of 40.
Okay,
so
that's
kind of by the board recommendation.
Yeah, and we use those recommendations in like breast cancer and other things too. So those are good recommendations. Truly, it typically takes a cancer 5 to 10 years to grow to a level where it can be of significance anyway. So I think that's kind of where those come from.
Right, absolutely.
All right, so that leads me to my next question: is a lot of our listeners are Facebook junkies. Would tell me, man, I got my dad. My dad had colon cancer. And I said, well, how old was your dad? Oh, he was 66. Okay. Does that send off red alarms to you, or is that,
I think, it's a tough scenario. I think if your family was diagnosed at a later age, 60s, 70s, 80s, unfortunately, the guidelines still say you would start at 50 or 40, whatever we talked about, right? Now, if somebody comes in with family history and symptoms, I think that changes the game a little bit, right?
Right.
Somebody said, hey, I have new onset constipation and nothing else has changed. I have rectal bleeding. I have pain. I'm losing weight without trying. These are kind of alarm symptoms that we say, I almost don't care about the family history. We got to get this checked out.
Yeah, let's hit those again. So those are actually signs concerning for cancer, right? You said rectal bleeding, where you used to have none before. And that can just be hemorrhoids, fissure, stuff like that. But if it's new and this is something going on, this is concerning. You said weight loss without trying, right? What else? Anything else?
Definitely any new change in bowel movements. Now, we have to put an asterisk behind that. Not everybody who has a weekend of constipation has to have a colonoscopy. But if somebody, has been regular their entire life, and now for the next month or two, their bowels are changed significantly. Right. They need to take laxatives. They're having discomfort. That's something that needs to be investigated. And particularly if you've reached that age of 45 or 50 and have not had a screening. That's kind of
that makes sense. Yeah, that makes sense. By the way, I've said this 1,000 times. Screening tests are the greatest invention medicine ever came up with. They are what saved your life. So, if you're coming up on 45, it's time to go see this man. It's time to go.
And I'll throw one more thing in there. A lot of healthy males over the age of 45 or 50 have concerns about doing the colonoscopy, I'll tell you the procedure itself is completely painless because you're sleeping. The toughest part usually is the day or the night before. You know, you have to drink a small laxative that's going to clean your bowels out. That's just kind of a natural process.
But that's changed too, right?
Sure. Yeah.
Tell us a little bit about that. I remember they used to have to always drink a gallon of the Go Lightly, which was miserable. That's changed, right?
So in fact, that has changed so recently within the past 2 weeks.
Oh, really?
They just came out with a brand new bowel preparation that is tablet formed.
Oh, wow.
And the tablets are pretty small. They're not the old school big tablets that patients had trouble with. I think that's going to be a big game changer. I mean,
that's huge.
There's no need for huge laxative solutions and feeling nauseous
But during your prep, you can still drink clear liquids and stuff like that, right?
Absolutely, yeah. We want you to stay hydrated. You know, clear liquids, broth, stuff like that. We don't want you to be miserable, but there's a process to getting the colon cleaned out.
And you got to remember, if it's not clean, if you're not pooping clear, then he's not going to see clear, and that's really important. I think that's really super important. All right, last one, and then we'll start going to you guys' questions. Tell me what you think about Cologuard. Cologuard, if you guys don't know, is a test that you can they can send you home. You take a little sample of your stool, you put it on this card, and you can even send it back. It's a thing you can even do at home. Yeah. There's been a lot of talk about this, and so many people are like, oh, I'm not going to do my colonoscopy. I'm going to do Cologuard. I'm not sure I'm ready to go there. I don't know. What do you think?
Well, you know, Cologuard, or the company behind Cologuard, has great marketing because the commercials are fantastic. It doesn't come with any of the information that you actually need. And this is a pretty common question nowadays. The first thing I'll say about a stool Cologuard test is it's not indicated if you're having symptoms. So anybody coming in with a symptom, you're not a candidate for Cologuard, right? Number two, if you have a family history of colon cancer, you're high risk, you're not a candidate for Cologuard.
Good
and
point.
Number three, if you've had polyps during previous colonoscopies, you're not a candidate. So any of those things are on your history, you can X that as an option.
Okay, when do you like it? When do you like Cologuard?
So I like Cologuard in a scenario where a patient maybe has other medical problems and we think the anesthesia might be an issue. We think the preparation's not going to be successful.
Great point.
At the very least, we get some good information to rule out. You know, we have to keep in mind, and we talked a little bit about this before, what are some of the limitations of the Cologuard? It has roughly, depending on where you read, about a 10% false positive and false negative rating, meaning 10% of people with Cologuard will get a normal test and may have something bad in the colon. And I'm not sure that I'm ready to kind of take that risk there. Right?
Sure.
If otherwise, the patient would do well with a colonoscopy.
But I think you just nailed it. I think if you're younger, if you have no family history, no previous polyps, things of that nature, no change in rectal bleeding, none of that, maybe it's not a bad test for you. I think and again, this is Radice's record here, not anybody else. I think I would still start with a colonoscopy at 45, and if that was clean, I think then I would say, okay, maybe
I think you're ahead of your time there, because I think in the next 3 to 5 years we'll see the Cologuard make it into the guidelines, and I think they're going to start with a colonoscopy. Yeah. And if that's negative, you may follow up. But
there you go.
Yeah, there'll be a role in it. I'm just not sure I'm buying that book yet.
All right, I agree with this man. Not only because he's the specialist, but he'll be doing my colonoscopy in the next couple of years. That's why. All right. This is a question from Jacqueline. In regards to bowel changes that could mean colon cancer, are there more specifics in regards to exactly what changes to look for? We kind of already hit on this, but let's do it again for Jacqueline, because there's some big things to look out for. Go ahead.
Yeah. So, again, one of the big things is some abrupt change in bowel function, right? I mean, look back 1-2 years ago, what's been your normal bowel function? If the past couple of months things are significantly changed and you haven't had a diet change, a new medication, you're not significantly stressed out, those are things that can kind of change the bowel movements out. But I would definitely say a change in bowel habits, number one. Number two, pain that we can't really answer, right? I mean, you come in with lower abdominal pain, we don't have an obvious source. You tie that to a change in bowel movements, we start, the ball starts rolling on that.
Right.
Number 3, I mean, these are more severe symptoms, but you'd be surprised how many times people see rectal bleeding and don't see anybody for a while. I mean, it's never normal to have blood in your stool, to have blood in your toilet paper.
That's
Under no circumstance. So that's definitely something I would look out for. And then I mentioned before the weight loss thing, right? There are many things that can cause weight loss, obviously. And some of them we do on purpose.
Yeah, exactly.
But unintentional weight loss is always a concerning symptom for us.
Right, and especially as you get older, too,
Sure.
And I would say, and there's some in-stage stuff. Now, this is when I see it, and he's way in front of me with respect to screen, but when he says change in stools, it also doesn't just mean diarrhea or constipation, right? It can mean you used to have larger caliber stools, now you have these pencil thin ones, things like that. It means like the tumor can be compressing your stool, things like that. I think
Absolutely.
we covered most of it.
Yeah, that falls within that realm of change in stool, caliber and consistency, that kind of thing.
Now, this is a question that, in my opinion, is extremely important. Extremely important.
Uh-oh.
Everybody wants to know the answer.
Here we go.
Why does your coffee make you poop? And listen, people, I have my coffee at 7 o'clock every morning.
Sure. Yeah.
I'm going to tell you, clockwork.
Okay.
By 9 o'clock, I'm just saying.
For many people, it's their natural accident. Yeah. I mean,
It's natural. But why? Why does it seem to work?
Well, I think two reasons. Number one, we know that caffeine itself is a stimulant within the GI tract. So particularly first thing in the morning, it augments the natural awakening of the colon, right?
Okay,
so there's kind of a cycle when you're sleeping where the colon itself slows down a lot, and as you wake up, your morning hormones come on, your GI tract wakes up, and most people drink coffee in the morning.
You heard that. Your morning hormones.
Yeah.
Come on. That's important. The morning hormones are important.
Yeah.
But I can tell you, it's. I think my wife is putting laxatives in my coffee.
Yeah. Well, she might.
She might be. And just to get me back for all.
I know pretty well. She might be. Yeah.
She's not going to decline or admit to that, but I can tell you right now it happens. Okay. And thank you, Wanda, for that questioning, because that's important. That's important. All right, here's one from Alan, and this one's actually more people buy one of these than you can imagine. I mean, truly, go on Amazon and look it up. If you've ever heard of the squatty potty. So Alan says, I bought a squatty potty a couple years ago, and this is, let's describe, this is like a thing where you actually can put it on the pot, and it helps you keep a proper, they call it proper posture, right, for a bowel movement. So first, what do you feel about the potty, the squatty potty, and is there really a proper positioning for pooping? I don't know.
Well, I mean, do I think everybody needs a squatty potty? Probably not. If your bowels are normal, if you're not straining significantly on the toilet, you should be fine. I do believe that sitting in that position that is provided with the squatty potty physiologically helps. If you'd be surprised how many things have to happen for your pelvic muscles to relax, for the axes to tilt, to actually get your bowels through. And that seated position with the feet elevated, the knees a little bit higher, is
so there's something
well
to
established.
it.
Absolutely.
There's something to it.
Now you could also stack some books, a couple cans. You don't have to go on Amazon and continue
you heard
to
it.
sit.
Campbell's tomato soup. Get your legs up there, people.
Put
get
your kids on the ground, whatever you need to do.
Whatever it is, just don't do it.
Yeah.
No, I actually agree with you. This is one we totally agree on. There is something to positioning, right? You have the levator muscles, you have the ischial tuberosity that connect the ischial rectal muscles. There is something to proper positioning for bowel movements, but at the same time, not everybody needs it. No. Most of the time, it works out just fine.
I'd say, Alan, if it works, just keep it going.
Keep it rolling. Yeah. If it works, keep it going. All right, good. Let's go to a couple. I wanted to touch on a couple of topics, which I think are important. One is something that you just see more and more and more of, and I think this is because we just didn't have the diagnosis, right? We used to just call this, we give it the definition of IBS, right? Irritable bowel diseases, syndromes, things of that nature. But they put the two big guys up there, right? There's Crohn's and there's ulcerative colitis.
Sure.
And this is something, and you can tell me, I think we're seeing more and more of it.
Sure.
Because I think we're getting better with the diagnostics on that. But I know that they vary so much in their symptomatology. So some people may get diagnosed with Crohn's in their 20s, and it just may be a little bit of blood in their stool. That was it, and they move on. Some people are crippling, right, in their 20s. So can you tell us a little bit about, and if they're so different, you can kind of pick them apart. Diagnostics, like how would you diagnose somebody with Crohn's? Does it always run in the family, or is this something if they say, my mom had Crohn's, what are my chances?
What's my risk? Yeah.
Yada, yada, yada.
Yeah. So, I mean, the first definition I'd probably define is, so that we're very clear, I would keep, irritable bowel syndrome, which is something we call IBS, completely separate entity from IBD. And I kind of hate that they only separate it by one letter, but
right.
IBD is the term that we use to encompass Crohn's and ulcerative colitis. So that's a completely different set of diagnoses versus irritable bowel syndrome. We can talk about that separately, but yes, so Crohn's disease, ulcerative colitis, I'd say typically gets diagnosed at an earlier age. I'd say teens, 20s, sometimes a little bit 30s. It tends to hibernate for a while, and there's a second kind of risk around 50s or 60s where somebody can present as their initial symptoms. And you're right, once somebody gets diagnosed with this, and I'll kind of go into that too, the first question is, what's the severity, right? There are people with Crohn's, ulcerative colitis that have very mild disease, easily controlled, first level medications, don't ever require surgery, and we can manage those patients very easily,
But how would you, let's say my 16-year-old daughter is having some new blood in her stool and some abdominal pain. Now here's the problem, right? Stress that's on kids these days, the stress that's on everybody these days. 2, she's a young girl, she may be starting the menstrual cycle. There's the belly pain, there's anxiety. I bring her to you and I go, hey, what do you think? My aunt had Crohn's. What do you think? How do you approach that patient?
Yeah, I mean, definitely you start with the initial wave of workup. Obviously, that's going to include some lab tests, specifically for inflammatory markers. If there's any component of diarrhea, there are very good stool tests we use nowadays that also can give us inflammatory, information. CT scan, right? I mean, we don't always send everybody for a CT scan, but if somebody comes in with these severe symptoms, they get a scan and they have inflammation in a significant amount of their GI tract, we progress to things like colonoscopy, right?
Now, how good are biopsies these days? I mean, what are our pathologists giving us?
Yeah, no, I think, the big thing with Crohn's and ulcerative colitis is that, in fact, it's diagnosed with a biopsy. Nobody can give you a diagnosis of Crohn's or ulcerative colitis based off a lab or an imaging test. You have to have a histology, a biopsy.
Yeah, and let's say that again. I just cannot, in my opinion, I cannot say the importance of that enough. It is diagnosed with pathology. It means tissue in hand, and that is important because I know Dr. Perez feels this way too. We do not want to give you a diagnosis of Crohn's.
Right.
That's the last thing you want to tell somebody.
That's the first question I ask patients when they come in and say, I have a history of Crohn's, I have ulcerative colitis, and I kind of say, well, let me see the paperwork.
Are you sure?
Right.
Yeah.
Because general colitis is not Crohn's disease.
Right, and you're not trying to be a jerk.
Right,
you just want to know that that's...
To me, and I don't want to be dramatic about it, but saying like, I think I have Crohn's is like, I think I have cancer. Well, do we have it or not?
That's
right. We have to figure this out. Because the treatment is way different for that versus everything else.
Right, and even biopsies can be inconclusive sometimes, right? I mean, you got to kind of go back and
sometimes forth. They just show inflammation. Specifically for Crohn's or ulcerative colitis, we see chronic changes there. There are very specific things that the pathologist looks for. So it's a very well-defined diagnosis, but it usually is a combination of, like I said, progression between labs, CT scan, and eventually colonoscopy type testing.
Okay, so tell me. Okay, so now let's say we got our diagnosis. It's Crohn's, and I know severity can be different, but let's talk about treatments. And treatments have come a long way. I mean, just in a decade or so, right? We've gone into from anti-inflammatories, right, mesalamine, these kind of things, to immune therapy, right? Where are we at now?
Yeah, I would say generally there's 3 levels of treatment. The first class is what you mentioned, the anti-inflammatories, the mesalamine-based therapies. The next level is called immune modulators, things like azathioprine, 6-MP. And then we get into what's called biologics, which are what you see on commercials, right? The Humiras, the Cimzias, the things like that. We are shying a little bit away from the immune modulators because we found that most of the long-term side effects come from that. So if you have very mild disease, we will do our best to get away with just the anti-inflammatories. I'll tell you the vast majority who don't respond to that, we do jump to biologic therapy.
Now, if somebody's, not to get too specific, but if somebody's just having the easygoing Crohn's, the easygoing ulcerative colitis, mesalamines, anti-inflammatories, do you still use prednisone and stuff like that during like a heightened?
We do. I hate prednisone. You know, I mean, it works very well for what it needs to do, but it carries probably the most side effects of any treatment option, right? And you talk about things like blood sugar elevation, water retention, irritability, insomnia. It's kind of a nightmare, right? But if somebody's that sick and you need to get them well quickly, that's what we use. Unfortunately, to me, if your disease is so severe that you need prednisone, then we're past the anti-inflammatory. We got to start talking about the next step. So prednisone or steroids should be looked at as a bridge to something else. It's never, oh, I'm on prednisone, my Crohn's is doing well.
Right, and for some hope for everybody, they're coming up with stuff all the time. I mean, this is new stuff all the time.
Yeah, there's about 6 or 7 biologics available nowadays. I mean, this has all come the past 10, 15 years.
Yeah, right. The Imuron, the Humira, like all these guys.
The Remicade, there's all kinds of different pathways that they treat now. I mean, it's pretty advanced.
Well, I mean, I'll give you a real pat on the back. I mean, I really enjoy it. That's why we're doing this. But I send all of my patients who have these issues to you, and I know that it can be tough as a physician, but it is just wonderful because you do not want to go to somebody who doesn't deal with this all the time.
Sure.
I mean, even amongst GI doctors, there's guys who like to take this on, and there's guys who they're not sure. All right, so I think we've nailed at least a lot of the IBD stuff down. Any other honorable mentions? Anything else you'd mention?
No, I think you mentioned a little bit also, not every GI physician wants to take these things on. I mean, it is a very involved diagnosis, and you have to have kind of time and patience with it. So just do a little bit of work in finding somebody who's interested in that.
Absolutely. For my bariatric patients, just because this is special. So actually, Dr. Perez and I get along really well because he's not just a GI doctor who stays in the office. He actually does advanced GI stuff and a lot of what we call them procedural GI, or what do you invasive or interventional GI. There you go, interventional GI. So he loves actually being in the operating room, which is really kind of cool. We've done some really, I got to pat ourselves on the back. We've done some pretty amazing cases, things that you actually don't see unless you're at big universities. Because he went to a big university, I went to a big university, so we've done some really cool stuff together. So he knows my bariatric patients well. One of the things, and it's obviously not just bariatrics, but one of the things they ask me all the time is, Doc, I have malabsorption, I got this little belly, what do you think about probiotics? And I got to tell you, 5 years ago, I would have just stuck my nose in the air and said, dude, you're wasting your money, go buy some yogurt. Yeah. But have they gotten better? I mean, is it?
Yeah, the short answer is yes. They have gotten better, and I think part of that is just market competition. There's so many options out there. I'll tell you specifically, at least from a GI standpoint, we don't have a general recommendation in post-bariatric patients to empirically start a probiotic, right?
Okay, so like the American College hasn't just said, yes, do this for everyone.
No.
But what are your personal thoughts?
So that being said, number one, I don't generally recommend starting a probiotic, right? And when I say probiotic, I mean you go to CVS or Walgreens, you buy the capsules, you take one every day, that kind of probiotic.
Because they're not cheap, right? I mean,
they're $30, $50 a month. So as a general rule, if you're feeling okay, as of right now, that's not a blanket statement. Number two, my experience has been 2 symptom groups that I find that get the most benefit from this are probably things like gas and bloating. Right? That's a tough thing for us to manage sometimes. We don't have great options, but probiotics fits in very nicely there, and the risk of probiotics is almost 0. So that group does well. And then also if you're having loose stool, I find that those types of patients seem to do well with the addition of a probiotic. And the other thing I always add to that is, worst case is we try it for a month or two. If you don't see benefit, we can stop it. There's no real risk associated. Nobody has ever gotten a serious infection or major side effect from this. So,
all right. Well, I'm going to put you on the spot. I'm going to put you on because I hate doing this. Do you have a favorite brand?
All right, I get no pay from this.
I know. Say it right away. All right. Come on. I'm gonna go buy some tonight.
Yeah.
Tell me what I'm buying.
So I typically recommend either Floristore or another one that's called Culturelle.
Are these over the counter? Or?
These are over the counter, but the strains that they have have probably been the most studied strains. So they have some science behind them, actually.
Yeah. So again. There's no endorsements here.
Right.
Yes. I just, people always say, if I wish I had a GI guy who was my best friend. I could just ask him what, So, which, by the way, I know you get abused all the time. I get abused all the time. But we love this stuff. We're nerds. We love this stuff. So it doesn't matter. So there you go. Abuse this man. There's his favorite types of probiotics. And I will say, I don't disagree anymore. I think there are some benefits to it. But what I used to just tell people is go get some active culture, yogurt and get to work.
Right.
But I think the benefits are there. All right, last question, and I won't keep you anymore. So we were talking about just general public these days. There's so many things out there on food allergies, right? Or I gotta go gluten free, or I gotta this, or I gotta that. I've questioned a lot of that. There have been so many cases that, somebody went gluten-free and like, oh my goodness, like it made a huge difference. I often used to question that and just say, well, yeah, but did you just eliminate so many things in your diet that, you just got better because you're not doing that?
Just eating healthier,
yeah. Yeah, exactly. Now, I think you can do biopsies and things these days, right? And help rule out a lot of that.
Sure.
How do you approach that?
Yeah, so, I think the big thing that we're probably talking about is something called celiac disease, right?
Okay,
which is essentially a true allergy or inability to digest and absorb gluten, right? And it does damage in the GI tract. And
gluten, let's just define that for everybody. Gluten is like a byproduct like we put in food, right?
Sure. It's in a lot of wheat products and things like that. It's very difficult to digest for a lot of people.
Right.
But there are certain things we look for in patients that have the full-blown celiac disease, right? And that is often diagnosed with a biopsy, right? So you get an endoscopy, you get a biopsy of your small bowel, we see those celiac changes, we have a diagnosis.
Okay.
That being said, within the past probably 5-7 years, I would say, they have found this group of patients that are, we term them now, non-celiac gluten sensitive, right?
Okay.
So they don't meet criteria for celiac, they don't show the changes on biopsy, they don't have any antibodies for celiac, but guess what? When they ingest gluten, they don't feel well. And when they come off of gluten, they feel better, right?
So you do the biopsies, you do the tests, and even if they're negative, you still say, hey, let's try a gluten-free diet.
I'm all for, let's say, a 2-week trial of gluten-free, see how your symptoms do. Now, I agree with you. Not eating gluten is probably healthier, right? And it includes a healthier diet.
Don't say that.
So
stop saying that.
You may be feeling better just because you're eating better, overall. But gluten specifically, and you got to keep in mind, if you're going to do a gluten-free diet, it's got to be 100%.
Yeah, I agree.
It takes us maybe a half a slice of bread to activate your symptoms if you're gluten sensitive. That's how much. So you can't just say,
that 12-inch hoagie I just housed on the way there doesn't count?
Right, Domino's pizza for a weekend is not,
But you're seeing some really good results for people who legitimately have, the symptoms. Okay.
Sure.
Awesome. All right, so personal questions to wrap this up. What do you think the greatest advancement in gastroenterology in the last 10 years has been?
Probably...
Because you've been out practicing for over a decade now, so what do you see?
I'd say probably the advancements in interventional endoscopy. The types of things that are available nowadays for large polyp removals, for tumors anywhere in the GI tract, for biopsying areas that were typically inaccessible. The kinds of things that can be done nowadays endoscopically are pretty amazing.
Yeah, so let me jump in real quick because this is something where this is kind of like around my business too. this was huge. I remember when you guys started doing this stuff where they actually can go in and inject under a polyp,
Sure.
lift it up, transect it all during your colonoscopy,
Right.
and then you never had to go to surgery, which is huge, right?
Sure.
People think surgeons are going to be upset about this. This is wonderful.
Right.
You can take out large polyps and even low-grade cancers, right? I mean, that aren't invasive under colonoscopy. That's amazing.
Yeah.
So,
yeah, it's definitely a huge benefit for patients, and like you said, you know, avoiding surgery for a non-cancerous polyp is a big deal.
unbelievable.
Yeah.
Unbelievable. So good. That's one of the good investments. One of the things actually we've not talked about, and I think we're gonna have to now just do a whole nother show because we're probably coming up on an hour. But we haven't even hardly talked about upper endoscopies.
Sure.
So we're talking about my belly hurts. I have reflux. I have this. We haven't even touched on this stuff. So unfortunately, we're running out of time. So we're gonna come back. We're going to do a whole part 2 on the upper abdomen, GI, ulcers, I got peptic ulcers, I got reflux, the doctor tells me I got a hiatal hernia, what is that, blah, 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 blah. But I think we're going to end it on, if you have not had a colonoscopy and you are 45 and older, it is time to see this man. So, brother, I can't thank you enough.
Thanks for
This
having
is
me.
awesome.
Thank you, guys.
Oh my God, this is fun.
Yeah.
Facebook, we love you. What does it say? Hi, that dangly thing in the back of, what is that? What is that dangly thing in the back of your throat?
Your uvula.
Uvula! That's your uvula! Wah, 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 wah. And some people are missing an uvula. I say uvula. Anyway, guys, that was so much fun. We do have a Valentine's Day special on self-care and how to take care of yourself. And then I think we're going to probably have to come back pretty soon for part 2 of this. It was awesome.
Thank you.
Thanks, Facebook. Share this video. Instagram and Facebook. Put this man's face on the map. All right, take care.
You just did a WAP lyric.